So another feature to talk about, and basically an internal feature, is this dense regular connective tissue that really surrounds and supports all four of the valves that we were looking at in the previous video. So what this cartoon shows you is that they actually are all found on the same plane, even though they are between separate things. Okay, so tricuspid, bicuspid are part of the AV between the right and left atria and the two semilunars. Very close together when you consider them from this aspect. Well, it turns out that these valves, of course, weaken the heart structurally, and this is it's a pump and needs to keep on pushing blood and withstand a lot of force. So the extra dense regular connective tissue helps to support and strengthen that, right? These also insulate the heart, and so we're going to discover that by having this dense connective tissue that does not conduct electricity between the atria and the ventricles, we will be able to control the electrical stimulation of that passes from the atria to the ventricles. All right. So on the right side, when we look inside, here's a lovely photograph looking inside a heart, black and white, but just really nice. Shows you the chordae tendineae, which are these dense connective tissue that function like tendons and strings to attach. They attach to these valves, the atrioventricular valves, either tricuspid or bicuspid. All right, and then they anchor to these papillary muscles shown here. And then other features you talk about are trabeculae carneae, so carneae meet, right, and trabeculae network, so the network of crisscrossing. Of course, this is just the features when we look at this. So atrium receives blood from the three vessels, following from the right side, and the three vessels, superior, inferior vena cava, and the coronary sinus. Blood is, right, poor in oxygen and moves on through. Well, in the atria, and this is actually true for the left as well, you'll see this muscle called the pectinate, which means comb-like muscle, which are prominent ridges. And when that right atrium, which is kind of peeled back in this image, when it contracts, blood will move through the tricuspid valve into the right ventricle, right? And this just talks again about what I've already mentioned, that the chordae tendineae attach the tricuspid valve to, or anchored to, the wall of the right ventricle through the papillary muscle, right? There's also this feature, it's not shown here, but you see it easily on the hearts that you guys are dissecting in a lab, called the moderator band, okay? And this more or less regulates some of the filling of the heart. And when it contracts, right, the blood will move from the right ventricle through the pulmonary semilunar valve into the pulmonary artery, right? So on the left side, you pretty much have very, very similar things, just a different name to the AV valve called the bicuspid or mitral, right? This just reminds you again that blood is returning, right? Went from the right side, went to the lungs, and returns through the four vessels, right, called appropriately pulmonary veins, to the atrium, right, the left atrium with its auricles, and when this contracts, blood moves through the bicuspid into the left ventricle, and the left ventricle looks very similar to the right ventricle. There's no moderator band, and when it contracts, it pushes blood then through the aortic semilunar into the aorta, right? So again, here's a cartoon showing the valves all together. Said valve's basic job is to control the direction and amount of blood, or again, flow means how much over what time. So valves are controlling this, right? The two AV valves shown here prevent backflow. So you want the blood moving from the atria into the ventricles, not the reverse, okay? And when the ventricles contract, we're going to have to close these, right? So these would stay open when the ventricles are filling, so blood can enter from atria to ventricles, right? And then we are going to close those, okay? And again, right valve is tricuspid, left valve is a bicuspid. The two semilunar valves shown here between the ventricles and their major arteries, all right, prevent backflow as well. And so they really honestly stay closed a lot of the time. So because remember the vessels are on the top, superior to the heart, so blood would flow backwards because of gravity. But it says this is when the ventricles relax, they're going to close. And when the ventricles relax, these would be open, right? Mentions too that there is no anchoring needed here for the semilunars because they are attached or fixed to the walls of the actual vessels. And they have 3 basic cups or cusps. So that works very well for us, all right? The opening and closing is really based on heart contraction. So here in this cartoon, we see what I was just talking about, the AV valves being open, semilunars closed. And this would be a typical filling heart, right? Relaxed heart. This is the AV valves closed and the semilunars open. So this would really be during ventricular systole especially, right? When it's pushing, right? So again, when atria and ventricles are relaxed, all right, these are going to be open. And when the atria contract, these are going to be open because, again, the atria, when they contract, are going to be pushing it into the ventricles. So we need these open so we maximize how much blood is entering the ventricles. When the ventricles contract, and this is right in the very beginning of ventricular systole, these AV valves are closed. In fact, that's what you're going to find is your first heart sound, right? And the ventricles continue to contract during this period that we call systole, all right? And they'll generate so much force or pressure that they'll open the semilunars as shown here, all right? And ideally, blood would then leave from the ventricles into the vessels and not be, again, moving back into the atria, all right? So the coronary circulation, as soon as the ventricles, and here the left side specifically, contracts and pushes blood, right, opens that semilunar valve and pushes blood into the aorta, we see there are 2 branches that come off immediately. So a right and left coronary, all right? And they're going to go on to divide and produce all the coronary arteries. They'll all come off of this. It's just branching out and getting smaller and smaller and smaller until they'll finally get to capillaries, okay? And that's what we mentioned you'd have from the left coronary. You'd have that anterior interventricular artery, also known as the LAD, or left anterior descending. And you'd have a circumflex that's major, right? And from the right artery, you'd have the marginal artery, and you'd have the posterior interventricular artery, okay? So it's part of the systemic, as I said, since we're moving into the aorta. Remember, the heart is a very large muscle, has a highly needy, because unlike skeletal, it'll never rest. And we never want it to fatigue. So it has to have a lot of oxygen and a lot of nutrients, and it has to have it continuously. All right? And this just walks through some of the divisions I've just mentioned to you. There is an awful lot of individual variation. So in other words, you could just take your fetal pigs and look and notice this, or the big pig hearts you have in lab, but no 2 hearts are exactly the same as far as where you find these vessels. They're in the same general area for the major ones, but then all the minor ones, there's additional branches coming off depending on the person, or going in different directions, basically. And you see a lot of what we call collateral circulation. So in other words, collaterals, like these 2 would be collaterals, this one and this one. They're very close together, and they're delivering blood really to about the same area. And this, of course, is a really protective mechanism, because if we have blockage in one of these vessels, we still get delivery through the other. So we call that collateral. And that's, again, a very important part that's different from person to person. All right? Cardiac muscle, as I said, is very much like skeletal muscle. So here it's just more branched. It's not the long cylinders. They tend to have only one nucleus, as you see here in this picture. All right? And then they have these intercalated discs. All right? And these are the junctions between 2 cells, and they have these features called desmosomes, and you'd see gap junctions here as well. So this is going to anchor the cells together so they can all work together, and the gap junctions are going to be able to spread electrical changes very quickly from cell to cell. So very important features histologically. It is very similar to skeletal, like I said, with the exception of the cells are single nucleus and shorter, highly branched, lots of mitochondria. All right. Also, and important for our discussion, is that cardiac muscle is autorhythmic. So it actually has groups of cells within the muscle itself that will spontaneously depolarize. It does not require a motor neuron to stimulate this muscle. All right? That's not to say that cardiac muscle isn't influenced by the nervous system. It is, and highly influenced, but it doesn't have to be influenced, okay? And that's different from skeletal. Skeletal absolutely required a motor neuron to tell it what to do and was divided in motor units for that purpose, all right? So two types of cells here. Majority of these cells are contractile, right? So they are going to be able to shorten, sarcomeres shorten, as you see a sarcomere, classic sarcomeres here, and cause a whole heart, right, to generate force like any muscle would, right? And like skeletal muscle and any other muscle, most of the cells are, they're excitable. They can spread the electricity, as I said, with these gap junctions. Small groups of myocardial cells are solely conducting, and those ones are the ones we call the nodal system, and they will spontaneously, that's the autorhythmicity, spontaneously depolarize and thereby initiate and then continue or perpetuate action potentials that will excite these contractile cells. So they are modified myocytes, muscle cells, that act more like nervous tissue than muscle. All right? Similarly, I said the cardiac does not fatigue, and they have a much longer refractory period. And if you don't remember what the refractory period is, it's a time in which another action potential, even if generated, the muscle won't respond to it. So, all right, and we'll try to make sense of that for you. So here's our conduction system in a cartoon, right? So it begins with these, right, nodes. These are solely conducting cells. They're not contractile. So the notable ones are the SA node, or sinoatrial here, the the spira vena cava entering the right atrium. The AV, or atrioventricular node here. This AV, or bundle of His, atrioventricular bundle, or bundle of His, to then down through the septum, the interventricular septum, into two bundle branches, and then up and out to all the ventricles at the same time through the Purkinje fibers, right? So we call that the nodal system. These are groups of, again, conducting cells that are basically generating, spontaneously generating, or initiating their own action potentials, and then sending them, right, then exciting nearby muscle cells and causing them to depolarize, which should lead to the contraction of atria and ventricles. All right, how do you get started? Right, an SA node, spontaneous, and anything again I put in italics is not, I'm not going to test you on, it's just to try to explain to anybody who is a little bit more interested. All right, so there is a spontaneous decrease in potassium and increase in calcium and sodium, which leads to an action potential initiated. At the SA node, right, we get impulses somewhere in the rate of 75. So there's 75 spontaneous depolarizations per minute. And it's actually even faster than that, but because the SA node, like the other nodes, is affected by the sympathetic or autonomic nervous system, at rest, you slow that down to about 75. So 100 is actually what you would have normally, all right? The SA node is it spontaneously depolarizes the most frequently, so the most often per minute, and so it is called the pacemaker, all right? All right, I say here again, the electrical impulses or action potentials then move rapidly across the myocytes in the atria, and when that happens, all of the atria will depolarize together, which we say will be the P wave, and the P wave should lead to atrial contraction, systole. All right, this moves into the inferior portion of the interatrial septum, right, just above the tricuspid, to the AV node. The AV node is the only electrical connection between the atria and ventricles because of that fibrous skeleton we mentioned on a previous lecture, right? So the action potentials are slowed down a little bit because of a change in the size of fibers here, and this allows then for the atria, as I mentioned over here, to fully contract. And this is important because that full contraction then pushes, it optimizes the blood that will then be in the ventricles before the ventricles begin to contract because of electrical stimulation. We'll pick this up on the next video, so I hope you watch this as you need.